Probably one of the most common errors that the US spends about $40 billion a year on is medication errors.
Mm.
So, when nurses are taught in school safe medication administration, they're given five or six steps that they should do on every single patient. And many times they skip those steps because they're in a hurry, short staffing or whatever, they're overloaded. It's just a really busy job. But that is what leads to patient harm and many times, unfortunately, patient deaths.
Imagine checking into a hospital, trusting the system, only to face a deadly slip up, a wrong medication, or a missed warning sign that could have been stopped. Dr. Julie Siemers, a trauma nurse who's battled chaos in ERs and choppers, rips open the truth about hospital mistakes. We'll expose brutal errors like botched handoffs or ignored vitals and arm you with sharp moves to stay untouchable. If you're ready to outsmart healthcare's hidden traps, this could be your lifeline. Hey, Julie, so great to meet you, and thanks for joining me today.
You're welcome. Thank you for having me.
Of course, and when I saw your bio online, I was super excited to talk with you because I think hopefully most people don't need to go to the hospital, but at some point, pregnancy, whatever it might be, people end up there at some. So because of your extensive background in this world, I was very curious because I don't think most people understand or think about these potential scenarios when there is a hospital visit. You've had all this experience in trauma units and emergency flights, and I was wanted to start it like, what is like the most common mistakes you see in a hospital that are putting all of us at risk, and maybe like a vivid example you have of how these happen in the first place.
Yeah, probably one of the most common errors that the US spends about $40 billion a year on is medication errors. So, when nurses are taught in school safe medication administration, they're given five or six steps that they should do on every single patient. And many times they skip those steps because they're in a hurry, short staffing or whatever, they're overloaded. It's just a really busy job. But that is what leads to patient harm and many times, unfortunately, patient deaths. For example, there was one, I did a social media post on this a couple days ago. A nurse in the ICU had two patients. One had a diagnosis of pneumonia, the other one was in septic shock. And so, there for a massive infection. Well, the nurse hung what she thought was the antibiotic for the patient with pneumonia. She didn't. She hung the other patient's medication, which is a really strong vasopressor to when somebody's in septic shock and their blood pressure is super low, it vasoconstricts to help keep the blood flow to the major organs. Well, the patient with pneumonia did not need that medication, and she couldn't figure out why the patient's blood pressure was sky high. Finally called someone to get some help, and they couldn't figure it out, and the lady died. And then they finally figured out the error. She was given the wrong medication. So that's an example of harm that can occur. One of the other really common ones that happen is misdiagnosis or delayed diagnosis or just not diagnosing the patient. It's about 33% of ER visits go misdiagnosed, undiagnosed. So, for example, one of the stories in my book is a patient who had brain surgery for a tumor, but the surgeons came out and told the wife, don't worry about it, it looked benign. Well, she and her husband took comfort from that, but the pathology report came back cancer. It got misfiled. The doctor never saw it, and the husband and wife never thought to even clarify or confirm that it was benign or not. So he ended up dying. It was 6 months later when they found this tumor the size of the surgeon's fist. So that's just horrific that those things happen.
And is this, of course, horrific? I 100% agree. Do you think a lot of this is, are we prioritizing maybe education, or how are these people getting hired to sort of be in these areas where a lot might be underqualified?
Well, it's interesting you should ask that question because there's a nonprofit patient safety organization. It's ECRI, ECRI, and every year they put out the top 10 patient safety concerns. In 2024, it was unprepared graduates from healthcare education, whether it's nursing, pharmacists, radiologists, whatever that may be. Uh, And that confirms what at least I know about nurses entering the work field not prepared for practice. There were three studies that were done: 2006, 2016, and then 2021, doing the same demographics, over 5,000 new graduated nurses that passed their board, so they got their license, and put them through a 5-hour exam. Part of it was written, and the other part was application of knowledge, like in a simulation lab. So in 2006, they found only 35% were safe and practice ready. And a decade later, in 2016, it fell to 23%. And in 2021, it was only 9%. Yeah,
Wow.
it's very scary. So that to me just says my message is more important than ever for people to understand we cannot be passive participants in healthcare. We have to take that um, partnership route, but also be an active participant.
And how you mentioned demographics, of course. Does it look at country specific? Because I know a lot of people, you go to a practitioner or whatever, talk to friends, they definitely, oh, they're from this country, they're from that country. How does the U.S. sort of stack up against Europe, Japan, whatever it might be? And my second question to that would be, are there certain age groups that are more at risk because of these errors? Maybe seniors, children, based on what you've seen.
Yeah, definitely. Seniors and children are the more vulnerable populations in any healthcare arena, whether it's knowledge, whether it's making it through surgery, those kinds of things. To answer your first question, we were ranked, the US, in a recent report, number 10 of the top 10 developing countries in healthcare. We have worse maternal child outcomes. We have worse, infection control. We have all of those things, more errors. But when you do the overall research, I do know that Canada and the UK both have challenges with patient safety, patients dying from preventable medical error. The only country that I read recently that's doing a really awesome job is Denmark. Yeah, a very different system that they use over there. They don't have litigation. They have committees that say, hey, the patient said you harmed him, and now here's the medical facility with the doctors and saying, yeah, we made a mistake. Let's make some compensation. So there's transparency. And that's, I believe, one of our biggest flaws in US healthcare is there's no transparency.
That's what I think is a huge thing. A lot. Well, Denmark, there you go. That one of the happiest countries in the world, right? Because they're
Yep.
not suing each other all day. But I do feel like there's transparency issues because a lot of people, when I talk with them, they always are. The doctor doesn't really explain this, and then the nurse might come in and say something completely different, or the nurse is guiding most of it, and then the doctor comes in for a second. So you do feel again rushed in any aspect. But I wonder the overlap there. Like you think long hours, maybe shift changes that are not the best for people on their time in terms of being awake that long at a hospital. How much of that do you think plays into it? Just exhaustion.
Yeah, it certainly does because nurses are working overtime shifts to cover the shifts because they feel guilty or bad if, hey, if I don't come in, that's going to make my coworkers work, have extra patients and work harder. It is a problem that we've battled in the US for a very long time is shortage of nurses. When I first moved up to Las Vegas and was working in one of the hospitals, they were actively recruiting in the Philippines to get nurses to come over and work here. Just anything to help, bolster the workforce. But what's happening now, I mean, I've been a nurse for 46 years, so I've seen a lot of changes, but what's happening now is nurses aren't staying in the profession because it is so draining, emotionally exhaustion, physically, as you mentioned, and they're finding something else to do after 2 or 3 years, or the nurses are going back and getting their nurse practitioner or working in consulting. They're not at the bedside. So this again leaves us as patients and families at risk for having nurses at the bedside taking care of us that don't have that much experience. It takes about 5 years to become an expert in the field of nursing, and that's only working in one area. So if you have a nurse that works ICU for a couple of years and then goes somewhere else, they're not an expert. They may be competent by that time. So that's
Yeah.
kind of frightening too.
Well, I would imagine, right? Because you want someone who is an expert, right, at your bedside. When because I would imagine there's a lot of people who are telling me this is what I think it is, and they're kind of being ignored to some degree, which could snowball into something bigger. Do you see tech being a part of this? Is that alleviating? Obviously, people are worried about AI and whatever out there, but do you feel that that could alleviate some of this concern or these errors?
I do. I guess it's been about a couple decades now that we've had electronic health records or electronic medical records. And that has certainly helped because I remember in the ICU trying to read a doctor's handwriting and get somebody else to come over and say, "Do you think it's this?" So it's eliminated that when they have to do computer order entry. That's helped. But there's also other problems like alert fatigue. For example, there may be 100 alerts for one medication that really don't even apply. But the problem with that then is when the practitioner, whether it's the nurse or the physician, gets used to ignoring alerts, then when something really important pops up and they're just used to ignoring it, they don't pay attention. So that defeats the purpose of that safety approach. And I'll give you an example. There was a medical malpractice case not too long ago of a patient that came in. She had a blood clot in her heart she had a automatic implantable cardiac defibrillator and they were going to take her to surgery. Well, she was on some medications. Well, she before surgery became unstable and had a cardiac arrhythmia, heart rhythm that wasn't sustainable for life. And so the cardiology resident called the attending. They talked about it and said, okay, well, let's give her this medication for that, which is a good medication for a lot of people, but they ignored on the automatic dispensing cabinet the alert that said contraindicated for this patient because she's already taken a different medication. Well, this actually happened 3 times with this same patient with 3 different medications. There was 2 other medications that were for nausea because she's unstable, she's getting sweaty, she's nauseous, and those were also contraindicated with the cardiac medication she was taking. Also override, ignored the alert, and she died. And so this medical malpractice case is going back to standards of care say that you need to look at these alerts. So that's a problem that needs to be fixed. The positive side, I really truly believe we've got a lot of opportunity. I gave a talk in May at a conference, and it was about predictive analytics that we can program AI to do with medical records, as well as real-time patient alerts. So for example, Susie's at the bedside with her brother and she notices he doesn't look right. She don't know what it is or what's wrong. But having a QR code where she could scan it and type in, someone needs to check my brother, and it goes to the charge nurse, because let's just say his nurse came in and said, "Oh, he looks just like a post-op patient. Don't worry, he'll be fine." And she's like, something isn't right here. That gut intuition is very strong, by the way, and usually right on the money. So it's using those kinds of things to track and trend lab values, vital signs that can paint a picture and do a real alert, a red flag to say, hey, this patient looks like they're early sepsis. Let's get them treated. So there's a lot of great potential too.
Yeah. Do you think that there's stuff technology wise that people should be using anyway, right? Like a lot of people are using watches or rings or whatever. Do you find any value in those in terms of being able to, catch these things? Oh, my heart rate's a little off. What's going on? I should go check myself in. Obviously, you worry when you get there. Are they going to understand, right? But do you find any value in wearables and tech?
Absolutely. Especially if someone's got any kind of health issues, and a lot of people do. A lot of people, older people have comorbidities, heart disease, diabetes, whatever. And these wearables are getting smarter as they should. Some of them can even tell you when you go into a heart rhythm that's like atrial fibrillation that's, you need to go get checked. They can tell your oxygen. I know the Aura Ring, I was reading on this, can actually sense the temperature changes that studies have shown indicate prior to you actually having symptoms of getting sick. And so it gives you that early indication or heads up. Yeah, it's cool.
Yeah, it is pretty wild that what it's going to be like 5 years from now, let alone what it's doing
Yeah.
currently.
Yeah.
So, but you train nurses, correct? Like in the
Hmm.
past.
Yep.
Now, if you were doing this today, what would be your approach to training 25 versus when you did it, knowing the success rates and all the errors that are going on?
It really boils down to the students in school understanding concepts because everything goes back to anatomy, physiology, and pathophysiology. For example, for a nurse to understand the difference anatomically as well as pathophysiology wise of oxygenation and ventilation. They're two parts of a process, right? And a lot of times the nurses won't understand the difference. And where this comes into play is another story I wrote in my book about a patient that was coming in for shrapnel removal from his eye. He was in Iraq and they got out part of it. Well, he was back for his second surgery. He was on a PCA pump, which is patient controlled analgesia. They just push the button when they're having pain. And he came through the surgery just fine. His wife kissed goodbye, said, I'll pick you up and see you in the morning. Well, the nurse just assumed he was sleeping, didn't count his respiratory rate, which we'll talk about in just a second, saw that the oxygen saturation was 96, 97%, which is in the normal range. And the next time she went and checked on him, he was dead. So what happens is when we're checking oxygen, especially in a healthier person, it can stay stable for quite a long time. But ventilation is the part of how many breaths per minute. And if our breathing slows down because of opioids or brain injury, then the carbon dioxide builds up. And that decreases the drive to breathe. So here the respiratory rate's falling from 12 to 10 to 8 till they stop breathing completely and then they're dead. So that's an example of a concept that has to be understood about why we teach what we do. But the thing is, if they don't learn it in depth like that, then they'll take those shortcuts and say it's not important to count respiratory rate. But what I teach, because of the research I've done, is the respiratory rate is the most sensitive and earliest indicator of patient deterioration. And there's been multiple studies. The latest one showed 80% of nurses admit they don't count the respiratory rate. And I believe the other 18 or 19% are lying
Most
because they
likely.
don't understand, how important it is to catch early the patient deterioration that occurs for multiple reasons, post-op or with pneumonia or with sepsis, those physiological changes, which means we can see them, monitor them, happen 6 to 24 hours prior to a cardiac arrest. That's plenty of time, in my opinion, to say, hey, Dr. Smith, something's wrong with Mr. Jones, right?
So what can a patient do? Like if you know you're going into the hospital, is there like what steps should you take? Can you prep your body before admission, to sort of make sure that you're on guard? Your family members, anything to tell them to not that every hospital is unreliable, but what can a patient do?
The first thing that I would do, and I tell this to everybody, no matter what, even if you aren't sick, is look at the hospitals in your area on a website called hospitalsafetygrade.org. Put in your zip code, find the hospital closest to you or the one you're going to go have surgery at. They are ranked A to F, just like college papers. A, awesome hospital. F, you're probably going to die or your outcomes are much, much worse in those hospitals. There are 22 categories of safety. It's a leapfrog hospital safety grade that takes all of the data and puts it together to determine. And it's really easy. You don't have to really understand a lot of medical terms, but you could look on the dashboards in each of the 6 categories. There's subcategories and say, okay, I'm going to have surgery. How does this hospital rank overall in their safety ratings with their letter grade? But how do they rank in the surgical category? So there's blood clots post-op. How do they do there? How do they do with respiratory or breathing problems after surgery? How do they do, with infections? And then have the conversation with your doctor and say, I see that blood clots are a big problem at this hospital postoperatively. What are we going to do together to make sure that I don't get one? And it really is becoming an informed consumer. that really is your best safety tool that you can do. The other really big thing is you've got to communicate and not be, like we talked about earlier, being a passive recipient. So know your health history, know your medications, look them up and know what they mean. And that is really the best start to do what you can do. When we know that communication breakdown is responsible for 70% of patient harm events, part of that is on the onus of the hospital and healthcare team, and then the other responsibility is the patient and their family. So it's sharing, hey, my mom doesn't look so good. And the nurse and doctor being open to say, well, what do you mean? What do you see in this different? Because we don't know your mom. Well, she's acting a little confused just because she's 70. This is not like her. And then we work together as a team and try to figure out what's going on. But that's what I talk about in my TEDx talk too, is the cuss words, how to communicate effectively, get the attention of the medical team when you say, I'm concerned, I'm uncomfortable, I'm scared, or this is a safety issue or situation. So those things should alert the team that, hey, something's going on here we need to check into.
Yeah, and is there a difference, I guess, between some people would say, "Oh, you don't want to go to a county hospital," or "You want to go to this kind of like." Do you see any difference in that private count? Is that in terms of the grades and quality of outcomes?
Yeah, I think it varies. You can have some excellent teaching hospitals or community hospitals, and you can have some that aren't so great. Again, I think it's going to be not just labeling one versus the other as better or not. What I will say about teaching hospitals, I think this is important for people to understand. There are residents, which are doctors, but they don't have enough experience. They're just new, either first year resident, second or third. They're supposed to consult with the attending physician, like the case we were talking about before with the medication errors. Some residents don't understand the severity of what's going on with the patient and may not call the attending physician. So that is, if you ever find yourself in that situation, that's a time for you to speak up and say, I think you need to call your supervisor because something's not right with my son.
So basically, just calling out right there on the spot, kind of like a go-to phrase. Just call the supervisor, and they should react and get that person in front of you.
Yeah, they should. The first story in my book, and actually one of the three stories on my TEDx talk, was exactly this situation. He was a 15-year-old boy that had chest surgery for a deformity he was born with, came through the surgery just fine, started having some complications the following day of abdominal pain. Then he starts getting symptomatic, meaning his heart rate was going up, his belly was getting distended, his hands and feet are getting cold, and his mom's like, something is wrong. She had no idea it was a resident. Otherwise, she would have escalated. She did not know this chain of command. Unfortunately, Lewis died on day 4 after surgery, totally preventable. All of his symptoms and signs missed by the nurses and the doctors. The pain medication that he was getting was an NSAID, a non-steroidal anti-inflammatory, and he ended up getting an ulcer that perforated and is what bled into his belly, and he died from blood volume loss, cardiac arrest. So,
That's horrible. Yeah. Every time you
yeah,
start a story, I'm like, I don't know if I want to hear
I
what
know.
happens. It's like awful.
I think though that people relate to stories.
Yes. Oh,
And
100%. Yeah.
if I were in this situation, like this mother, I would know if I don't speak up, my son may die. So I'm going to be the squeaky wheel. And learning that there is a hierarchy. You speak to the nurse. If you don't get resolution, you talk to the charge nurse. There's a house supervisor that's over all of nursing in the hospital. And then there's the administrator on call, which is a hospital C-suite or, the CEO, CFO, somebody that you can call and say, we got a problem here and nobody's listening.
Right. Well, so I wanted to get into your book specifically. For people listening, how to take us a journey through your book? Like, what can people learn from picking it up, and what can they expect to questions, answers, things like that?
Yeah, I wrote it because there's just not an awareness of patient harm. We all assume that our doctors are going to take really good care of us. And I'll preface this by saying doctors and nurses don't intend to ever do harm. They really do want to safely take care of patients, but the system is so broken with errors and not fixing those errors that it continues to lead to continual perpetuity of patient harm, it seems. Patient harm was mentioned in the Journal of American Medical Association in 1955. It's 70 years later, and we still have a problem. So I think that I wrote this to inform people, and many times you don't even know you need it until you're in the hospital going, I'm in a foreign country. I have no idea the language they're speaking. I have no idea what to expect, what's normal, what's not normal. When do I speak up? And so the book breaks it down in chapters of how to pick your physician. You should have someone that you feel safe and comfortable and that you can ask questions and doesn't medically gaslight you, because that really does happen, unfortunately. How to pick your hospital, like we talked about, hospitalsafetygrade.org. What are your Bill of Rights? And then we walk through, if your family member's having surgery, what you should know. What is an informed consent? What does a pre-op checklist look like? What is that for? So it really is broken down into those types of areas. If your grandmother has a tube feeding, for example, which is a tube down her nose to feed her because she had a stroke, what, as a family member, should you know? And this story actually came, one of my assistants at my previous job at the nursing school told me that's how her grandmother died, that they left the head of the bed flat. The nurses came in to give her a bath and change her bed. Well, the head of the bed should never be flat with a tube feeding because they have a chance to aspirate. That tube feeding can go into the lungs pretty quickly if they're laying flat. If the family had known that, they would have just put the head of the bed up or called the nurse back and said, hey, I think, you know, but you wouldn't know that, right? So it's
Well, you
those
would
little
think that,
things.
yeah, you would think they're doing the right thing. So you're kind of
Right,
putting all your trust into them.
right. Yeah. And you really can't. And it's not that we're going to assume harm, but we're going to be informed and educated so that we can stay safe and keep our families safe.
And is there any pushback that hospitals might give you when, because they always say like an informed patient kind of scares right the system, are there hospitals or nurses, doctors, whatever, that kind of push back when patients come in with the being informed and having the data? Is that something you've come across?
Oh, yes, unfortunately. And that's why I think my mission is to change the culture. And I really believe the only way we're going to change it is patients insisting that the doctor come back in the room and say, hey, I didn't understand a word you said. You said my mom's got congestive heart failure. We're going to do an echocardiogram and then we're going to put her on a diuretic. What? What does that mean? And I think we just need to insist on those conversations to say, help us understand it. And we should be working together as a team. I will tell you that I've seen this when I had students in the clinical settings and they're interacting with a nurse. They'll ask the nurse something and the nurse won't know, but she'll make up an answer.
That's not comforting.
Yeah, and I think, they're intimidated sometimes by patients' family members because they don't know it all. But here's what I always told my students. I'm never going to know it all, and things are going to change. We had one patient we were taking care of that we were looking at the chart, and my student said, what's this? A procedure that they're going to have this afternoon. And it was a pleurodesis. And I go, I haven't done one of those in so long. Let's go look it up. And it's all about humility. We don't have to know everything, but go find the right answer or say, let me get back to you on that.
Yeah, because I think people would appreciate that more to say, I'm going to make sure I bring my supervisor, like you said, in, or I'm going to consult with that person to make sure we're all on the same page so you feel more comfortable. And I notice a lot of times you'll just see nurses just come and go and come and go. Is there sort of a difference when maybe the patient at nighttime hours are sleeping, right? And I don't know how long the shifts might be, but sometimes they go to bed, they wake up, it's a different nurse, but they barely saw the one that was there. So it's this constant like revolving door of people.
Yeah.
How does a patient and a family, again, you might tell all this to one nurse, but then you come back and it's someone completely different.
Yeah, that's a really good point. I also tell families and patients to take notes, write down what this doctor said or this nurse said. Just, you're not expecting problems, but just so you can keep it organized in your mind too and say, but the doctor yesterday said this, help me understand. Always come from a place of curiosity, help me understand, or I'm curious about. And that seems to take off a little bit of the roughness of, we're not attacking, we're just trying to partner. I think that's a great way to do it. But you also bring up a good point. The most errors happen at shift change. Again, because pertinent data does not get relayed to the next nurse or the next shift that they may not think is that pertinent or vital, and yet it truly is and impacts what happens to the patient going forward. So that's another reason I think to keep notes is just say, hey, well, this happened last night, so we just want to make sure that tonight mom doesn't get out of bed by herself or whatever.
Yeah. And what about personality? Like some people will say, my doctor has no bedside manner. Okay. The next one, very, 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 holding your hand, so to speak, right? But when it comes to nurses, sometimes you get that same approach. Some might come across as cold, some might come across as very warm. How much of that, and again, they can't be robotic, but how do you convey that to, or do you, when we're teaching and with nurses, like this sort of basic level of, let's just make these people feel like we are, holding their hand. Yeah, caring, right?
Well, nurses have had the privilege of having the title by the Gallup polls as the most trusted profession. And it's been decades. The only year we lost it was in 2001 during 9/11, where they gave the top award for that to the firefighters, right? But it is, we are trusted. We're looked at, we've got this probably culturally, picture in our mind of, the angel or Florence Nightingale, right? And we try to teach professionalism to our students that you don't bring your problems to work. I always look at it like whatever I got going on at home, that patient in the bed's got it worse than me, and to have the compassion. You can't teach compassion. You can try, but that comes from the inside of, that individual, I believe. But it's really teaching them that this person, whatever reason they're here in the hospitals, having a rough time and they need our compassion, not just an IV start or a pain medication given or a dressing change. We need to look at the whole person, but that doesn't always happen.
And when someone's sort of going through, hopefully nothing as horrific as a lot of the stories you've discussed. When they do have questions, say you're kind of getting just a bad vibe from the nurse, and you just don't really think that person understands what's going on, or your needs are not getting met. How do you sort of, and you might be not stuck, but like they might be on that shift for the next 8 hours. And you feel like, oh, if I go and sort of tell on them or get their supervisor involved, it's going to be not good for my grandmother. Do you have like tips for how to handle situations in that regard?
Yeah, a lot of people say that they have fear of speaking up for that exact reason. The three P's, I would say: be present, which means be there, especially during shift change if you can, or when the doctors make rounds. But also, I say be present in your heart. Assume good intention. Assume that you're going to work together, even if they're cantankerous in the beginning or whatever. The next one is be polite. Just say it as nicely as you can, even if you're frustrated. And then be persistent. If you think something's wrong and this nurse isn't acknowledging your fear or giving you a good rationale of why dad's heart rate is 100 right now and it was 60, something's wrong, right? No, it's okay. They get like this. Well, and you're thinking, I don't know, that doesn't sound right, or whatever it may be persistent. And that's when say, hey, go to the charge nurse. I talked to the nurse about my concerns, and I just don't feel like it's being taken seriously. There is not supposed to be any kind of retaliation, but I can understand the fear for sure.
I think because your loved one's care, life, whatever is in the hands of these people, that you don't want to get angry, right? So
Right,
it's
right.
that fine line. You feel I think a lot of people feel that they're on, especially when it comes to a child, right? Of all things. So what was can you break us the TED talk down that you did? Because that sounds very interesting. You have a lot of great tips in there.
Thank you. Yes, the TEDx audience, the intent is to appeal to as large of the audience as you can. And I gave it a lot of thought because I don't want to upset or anger or isolate healthcare providers. It's my profession. But I also know that patients and families are very vulnerable. So that's what I wanted to approach this talk with is how the underlying message, even though it's titled How Not to Die in the Hospital, the underlying message was partnering and building that bridge between healthcare providers and patients and their families. So we as healthcare providers need to listen, and then patients and their families need to speak up and voice their concerns or ask their questions. Yeah, and the three stories that I shared, unfortunately, were all, pardon me, true stories. I got permission from each of their family members to share it and have their pictures, and each one of them was a different scenario about the team not listening to the family members and the consequences of not doing so. Because the family members, if they're concerned, to me, we need to check it. We need to make sure. Could they be panicking for nothing? Maybe. But is there also the opportunity or potential that something could be truly wrong and we need to check? And that was the idea and the intention of just raising awareness of this problem. Over 250,000 patients die every year here in the US from preventable patient harm. If you break that down, and I honestly believe that's a very low number because many are unreported, there's a lot of lack of transparency. But if you break down 250,000 patients per year, some studies say as high as 400, that's 684 patients every day. That's not anything to sneeze at, right? It's like, holy smokes, when you see it in that perspective. And then we always compare because healthcare is a high risk industry, just like nuclear, aviation. And we've learned things from aviation. We have simulation now. We have checklists. Like there's doesn't matter if the pilot has flown 10, 15,000 flights, they will always do a pre-takeoff checklist and a landing. I learned that when I was in a flight nurse on the helicopter too. They always did the same thing. Well, in medicine, it's not always applied. We don't always do checklists, although there's been evidence how they help prevent harm. So, with that being said, if the airline industry, if we're looking at just commercial, because private airplanes, it's probably too hard to measure. But if we look at just commercial accidents that people have died in 20 years, over it's almost 21 years, 239 people in that 20-year span as compared to 684 every day. So we got a lot of fixing to do.
Yeah, especially when you put it in that perspective with those numbers. If you could wave a magic wand, for example, what would be the one thing if you could just start a change in the healthcare industry? Like where would be the first thing you could do if you could just have a wand and just, okay, here's what we're changing effective immediately?
Transparency, number one. If a patient brings their family bring a lawsuit to the hospital, there was a study done not too long ago that 80% of them have to sign an NDA. They can't disclose. If we're not disclosing what the problems are, how are we ever going to fix them? For example, Vanderbilt Hospital several years ago had a nurse that gave a paralyzing agent to a patient instead of an anti-anxiety medication. Put the patient in the CAT scanner. They weren't monitored. 30 minutes later, they bring out the patient who's dead. They resuscitated her. She lived a couple days, but she had brain injury from lack of oxygen for that long. So Vanderbilt, and it's all over the news. I'm not telling on them that people don't know, they put natural causes of death on the death certificate, which was not the case. They fired the nurse and settled with the family. Well, when an anonymous tip came in that said, here's how the patient really died, they were given the wrong medication. Then they were forced to do an error analysis, a root cause analysis of the error. And what they found was a minimum of six up to 10 systems errors that contributed to allowing this nurse to make this egregious mistake. That was the first time she'd worked in the radiology department because she was floated down there. The system where she got out the medication, she was allowed to search just by letters, and that's how she pulled out the wrong medication. But because the system didn't work well, again, we're talking about overriding things that shouldn't be. And she just hit override when it said caution, paralyzing agent. She didn't even notice, didn't even see. So there was also not a policy in that hospital to monitor patients if they were even getting the correct medication, which then would have caught, wait, this patient's in the CT scanner, but her heart rate's dropping. We need to stop the scan and bring her out and assess her. So, multiple errors that contributed to one nurse making a medication error.
God, that's
So,
horrible.
transparency. Yeah, we've got to be able to say and learn from other people's mistakes. It's not about firing people and throwing them under the bus. Very, very rarely are mistakes or errors made on purpose. You have those few in the news that are just freaky, weird, like a sociopath person or whatever.
Yeah, I've seen those.
Yeah, but most of them is just human error. But how do we prevent that? We fix systems errors, and we only can do that with transparency and just saying, hey, I'll give you another example. There's something called a near miss. Like I almost made this mistake. They're not reported in most facilities because, again, the blame of what do you mean you almost made a mistake? I was listening to this webinar the other day, and they were talking about how they changed their culture and please report any near misses so that we can learn from them. And their near misses doubled. And of course, the legal team was kind of freaking out, administrative offices, but they said, we've always had this many. They just weren't reported. So now, but you can see the errors that we had have also been cut in half. So it's a shift in mindset to say, how can we fix this problem? And the only way you can fix it is look at it.
Yeah, I think that transparency is huge because I think a lot of these, no one wants to say they're wrong, and no one wants to get fired. No one wants to have to, right? Like, but the fact that we're not playing with small stakes here. They're playing with people's lives. So it has to change. And is it also because there's so much, the way the US is set up and in the healthcare system here, that there's always the potential of a lawsuit. And that's kind of shielding both sides because patients want to sue, the hospitals don't want to get into lawsuits. Is that sort of always in the back of their minds?
Yeah, of course. Litigation is what they try to avoid because when there is a lawsuit that's settled against the hospital, they're usually millions of dollars, if not hundreds of thousands. But most patient harm lawsuits don't even get filed because it costs the law firm about $200,000 just in depositions and the cost of putting expert witnesses, videographers, all those things. So they're not going to take on a lawsuit unless it's so egregious of the harm that was done to the patient and they're pretty sure they can win. They won't even take it on. So unfortunately, most patients and their families, even if they suffered harm, don't really have a route to resolve this, which I think is terrible. But there's also studies out there that say, and I hope they're teaching this in medical schools, many, many patients and their families have said, if you just would have acknowledged what you did and said sorry, and here's what we're going to do to resolve the problem so it doesn't happen to the next one. But they don't operate like that. There may be a few, but overall, they just hide it and keep going.
Oh, yeah. What do you think for people? They want to learn more. They want to get as much knowledge as possible. You've given out some great websites. What about your website, connecting with you, your book? What can they learn from offline, getting involved with what you're doing in your mission?
Thank you. Yeah, on my website, I've got blog articles that I put out. What is the importance of respiratory rate, that type of thing. In the book, we talked about a lot of the content that's in there. I'm going to say too that I know a lot of people are afraid of AI, but I wouldn't suggest Googling your question because in the Google search, you can get all sorts of wonky stuff. But if you use AI and you can use several different ones to compare, your information that you're going to get is going to be a lot more reliable. So, for instance, if your doctor puts you on a blood thinner after you've been diagnosed with atrial fibrillation, for example, and you don't remember what they said when you were home or you're being discharged or whatever, just put it in ChatGPT or Gemini or Poe or Claude, any of those, and just say, I'm on a blood thinner for my heart. What should I do? What are the precautions? What should I look for? so that if something happens, like you fall and bump your head, that should be the first thing that you say when you go into the ER is, hey, I'm on a blood thinner, because that's going to alert them. We probably need to get a CAT scan right away. Kinds of things. I think it can just educate you on your own body, your own health, your own medications to be as informed as you can. And then, if you're going into the hospital for a specific kind of surgery, find out what the complications are and then work with your doctor and say, okay, I'm an asthmatic. I don't want to have breathing problems after surgery. So what can we do to avoid those things and take the proactive approach?
Yeah, I think people are afraid of AI, and unfortunately, it's here to stay, and it's just going to get stronger and stronger. But if it's going to help you become your own advocate, and maybe your wearables are connecting with your AI, and they're all kind of speaking together, so when you go in, you're doing a lot of the job for the team of healthcare providers. But again, working together for the greater outcome, it's hard to say that that's bad.
Yeah, and I think the average general practitioner or doctor that you're going to go see in their office, they're seeing a patient every 6 minutes. So the more informed you are, and then you could get to the succinct information and convey that important information as quick as possible, then you'll probably have better outcomes, I
Exactly.
think.
Yeah, no, I agree. I agree that the time you get with your actual doctor is not much. So being able to maximize that time as well with the data. So you're not asking basic questions that you already have the answers to. And you, like you said, know your own body better than anyone else because, right, you're the one that's there in it and the one that's going to take care of it the most and care the most.
Yeah, yeah, for
So
sure.
what is your website though for people to visit?
It's drjuliesiemers.com. You can also find me on TikTok, Instagram, Facebook, drjuliesiemers.com. And I try to give a lot of TikTok is probably my biggest audience. I started a year ago with 11 followers, which was my family. And now I've got like 21,000, which is great. I'm reaching people with, like the one I posted yesterday was a case about a burn patient. What should families know if your family member ends up with a burn? What are the four pillars that the nursing team and medical team should be doing, just tips, questions you should ask. How do you communicate? Tips that are, I find in healthcare news, like the poor little boy that was swimming and got an amoeba in the lake that went to his brain. It's just, hey, public service announcement, just hold your nose if you're going underwater in any warm water body of, lakes or streams or whatever, just to try to be safe in multiple ways. I mean, it's a lot to cover, right?
Yeah, no, that's great. So people can connect with you there, go to your website.
hmm
And your book, where's that available?
It's on Amazon. There's a link on my website as well. Surviving Your Hospital Stay, a nurse educator's guide to staying safe and living to tell about it. That's the long title.
Just in speaking with you for almost an hour, I mean, thank you. This is like people need to hear this. People need an advocate like you with all the experience and all of the stories, all the data to sort of put it together. And you're not fear mongering. You're just like this. Here's the data. Here are the numbers. This is why
Right.
you need to be aware. And I think that people need to hear this, like I said, because we're all going to be there at some point. So being armed with all of this quote unquote ammunition that you're providing, I think is invaluable for people because we want to minimize these mistakes. And I think this is a lot of how they could start to do that.
Yeah. I'm also, stay tuned, look on my website or whatever, because I'm actually looking at an app right now, developing an app that would make it just easy to go to on your phone and say, what are normal vital signs? What do I do in the ICU? Just to make it the information more accessible. So, yeah, it's kind of fun.
I would download that tomorrow.
And that's what it's about. I mean, that's how we're going to keep ourselves safe, informed, educated, and empowered. And when you speak up for your patients, for yourself as a patient or one of your family members, if they're in this situation, just know that if you don't, harm may occur. And so just find the courage to say, hey, doctor, I'm just not really comfortable with this. And again, just saying it politely, but we have to learn to speak up because that is what's going to change the environment that we're living in now, because healthcare is just, it's challenging, especially with the cuts that have come out the last or that are coming with Medicare, Medicaid changes. It's more important than ever.
Yeah, people just need to be informed and stay on top of themselves and use the data that people like you were giving them. So thank you again for your time today and for sharing this message.
You're welcome. I appreciate you having me, and I hope people enjoy it and learn something. I always ask my students, did you learn something today?
I sure did.
Good, good. I'm glad.
Thanks so much, Julie.
You bet. Bye bye.